Thank you. Thank you. Good afternoon, everybody. And thank you so much for the kind invitation, Dr. Tosi. I'm Smita Jha. I'm at the NIDDK, and my research focus is parathyroid hormone disorders of parathyroid hormone, primarily focusing on excess and resistant disorders of PTH resistance. So today, I'm going to talk to you about the genetic insights and advances in the field of primary hyperparathyroidism. So I have nothing to disclose. Uh, sorry, just quickly make sure. Jeez. Jeez. Okay.
All right, we're not seeing the presentation mode. We're just seeing the.
Okay. How do I do this?
There we go.
This is good.
Yes.
Okay, good. Sorry. Okay, so nothing to disclose. So I'm going to get started. A quick overview of what I'll talk about today. We will first discuss the skeletal manifestations in primary hyperparathyroidism, and then move on to discuss mechanism of action of PTH on the skeleton, and then change gears to discuss genetics of primary hyperparathyroidism and review the heritable syndromic forms and the heritable non-syndromic forms of primary hyperparathyroidism. So, patients with primary hyperparathyroidism typically present with hypercalcemia. And so, how do you really process hypercalcemia in the clinic? And so we typically get the routine labs, which calcium, PTH, phosphorus. And then the way we think of it is typically to categorize it if it's PTH mediated or if it's not PTH mediated. When we come across this branching logic, uh, we think of PTH mediated disorders when the PTH levels are appropriately suppressed for the level of hypercalcemia. And in terms of PTH mediated disorders, we categorize them as a primary parathyroid problem or a secondary hyperparathyroidism, which is in response to hypocalcemia, which could be because of chronic kidney disease, vitamin D deficiency, or malabsorption, and tertiary hyperparathyroidism, where there is autonomous PTH secretion due to severe parathyroid hyperplasia. And then it when PTH levels are actually appropriately suppressed, the hypercalcemia may be mediated by PTH-related peptide, as seen in humoral hypercalcemia of malignancy, or could be mediated by vitamin D125 dihydroxy, which, as seen in lymphoma or granulomatous disorders, or could be vitamin D mediated, or could be because of some of these other conditions, such as genetic conditions such as Jansen's disease or 24-hydroxylase deficiency, or the milk alkali syndrome, or due to some of these drugs such as lithium, teriparatide, abaloparatide, etc. For the focus of today's talk is going to be primary hyperparathyroidism. Uh, so, how do these patients typically present to the clinic? So, while the presentation with hypercalcemia was true a few decades ago, In today's times in the Western world, about 80% of patients are asymptomatic and diagnosed on routine testing. However, these patients may have some of these manifestations. So, in terms of the skeleton, and we'll take a deeper dive into the skeletal manifestations, but briefly, these patients will could have fractures, may have osteoporosis, and rarely, in less than 5% of the cases, we could find brown tumors or what we call osteitis fibrosa cystica. In terms of kidneys, these patients may have polyuria, polydipsia, or they may have kidney stones or calcium deposits in the renal medulla. In terms of the GI system, patients may report constipation, nausea, vomiting, or may have had pancreatitis. The neuromuscular and cardiac manifestations are somewhat less consistent across studies, but patients may report poor concentration and fatigue, or they may report palpitations and arrhythmia as well. So, what are some of these skeletal manifestations in patients with parathyroid hormone excess? So, I'm presenting to you this patient in her 20s that we saw. And this is actually a patient with pseudo hypoparathyroidism, and I will clarify that in a little bit. But basically, patients with pseudo hypoparathyroidism have resistance to the action of PTH in the proximal convoluted tubule, but their skeleton remains sensitive to PTH. And the reason I'm choosing this patient is because her PTH levels are 5,000 picograms per ml, which we don't typically see in a patient with primary hyperparathyroidism. And it's just a good, exaggerates the effect, the skeletal manifestation. So this patient, basically, the 23-year-old female, and you can see on her hand X-rays here on the left, what we call subperiosteal resorption. Subperiosteal resorption essentially is a radiographic finding where there's replacement of the sharp cortical margins with the lace-like fuzzy surface. And it's most prominently seen in the middle phalanges, as seen in both her in bilateral hands, actually, this patient's. And you may also see that in some of these other bones in severe disease, and you can appreciate that on this patient's radius as well. It typically occurs on the radial side, as seen in both the hands of this patient. You also see an expansile cystic lesion with thinning of the overlying cortical bone in the radius of this patient. And again, this expansile cystic lesion with overlying cortical bone. And there is subperiosteal resorption seen on the femur, in the femur of this patient as well. Now, let's take a look into the craniofacial manifestations of this patient. And you can see this patient's skull X-ray showed a speckle pattern with salt and pepper appearance. You can see diffuse generalized speckled appearance on her skull, and then hypertrophy or an enlargement of both the maxilla and the mandible. You can also see this is an axial CT of the same patient, and you can see these expansile lesions in the sphenoid bone of this patient and the temporal bone. And again, look at her calvarial bone. So you can see diffuse thickening, prominent thickening of the calvarium with sclerotic bone deposits and the resorption of the outer table of the bone. So what really, and this is a pattern that we have seen in some of our patients with parathyroid cancer. I say that because those patients have much higher levels of PTH than what we typically see in benign parathyroid adenomas or benign adenomas. And so but this patient so far has been the most dramatic case that I've seen. So I wanted to present her films. And what these X-rays really tell us that these patients appear to have a predominant proliferating or expansile effect on bones of the craniofacial skeleton, but a predominantly lytic effect on the long bones that undergo endochondral ossification. So I had mentioned to you that I'll come back to pseudo hypoparathyroidism. And so let's review the parathyroid hormone signaling pathway. So both PTH and PTH related peptide bind to this 7 transmembrane G protein coupled PTH1 receptor and signal through cyclic AMP as a second messenger, resulting in phosphorylation of cyclic AMP response element binding proteins, which translocates to the nucleus and regulates transcription of target genes. PTH1R can also signal through some other pathways, but its cyclic AMP appears to have this pathway appears to have the most important role in regulation of calcium homeostasis. And so, what are some of the disorders of this dysregulation of this pathway? So, when you have primary hyperparathyroidism, you get PTH excess, PTHRP excess, or PTH-related peptide excess is seen in humoral hypercalcemia of malignancy. This is excess of PTHRP is also reported in association with congenital anomalies of the kidneys and urinary tract in children. Gain of function mutations of PTH1R receptor is seen in Eichen syndrome, and constitutive activation of this receptor results in what we call Janssen syndrome, Janssen's metaphyseal chondrodysplasia. And then we know that somatic gain of function of GS alpha results in fibrous dysplasia, and germline loss of function of GS alpha results in pseudo-hypoparathyroidism. So we've reviewed some of these disorders in the pathway. Now let's look at what are the skeletal findings in some of these other disorders. So here I'm presenting to you an axial CT from a patient, a 39-year-old female with Janssen metaphyseal chondrodysplasia. And what you can appreciate here is again these proliferating expansile lesions in the sphenoid and the temporal bone of this patient. Now, this is work by Dr. Michael Collins, and he had basically reported on the similarities in these conditions. So on panel A, you can see a patient with primary hyperparathyroidism, and you can appreciate the generalized calvarial thickening in this patient. And panel B shows a patient with pseudo hypoparathyroidism. And again, you can see the diffuse calvarial thickening in this patient. Panel C shows a patient with hypoparathyroidism on pharmacologic doses of teriparatide, and you can appreciate the calvarial thickening in this patient here. And panel D shows a patient with fibrous dysplasia, again showing calvarial thickening. And so clearly what we can appreciate that while the effect of excess PTH signaling on bones that undergo endochondral ossification appears to be predominantly lytic, the its effect on bones that undergo bones that undergo intermembranous ossification appears to be mostly proliferating or expansile effect. We also should remind ourselves that craniofacial skeleton appears to embryologically originates from the ectoderm, in contrast to the bones of the axial and the appendicular skeleton, which originate from the mesoderm. Now, let's take a look at the histological features of these disorders. Now, in this panel, you can see this is the iliac crest biopsy from a patient with primary hyperparathyroidism. And what you can appreciate here is these extended resorption surface shown here with these black arrows. And then you can see the thin cortex with increased porosity in these patients. Just to show you the contrast here, this is a patient with hypoparathyroidism, and you can appreciate here these thick cortex in these patients with well-connected trabeculae. And then I'm going to just show you, this is work from Dr. Boyce. This is histological features from a patient with fibrous dysplasia. And what you can appreciate here is marrow fibrosis in these patients, shown here with FT. Again, these immature woven bone, increased deposition of osteoid, and this giant cell osteoclast. Right, so uh, some similarities. Now, let's take a look at the skeletal effects of excess parathyroid hormone related peptide in adults. And this takes us back to this work published in 1982. And basically, there were 7 patients with humoral hypercalcemia of malignancy and 9 patients with primary hyperparathyroidism who underwent iliac crest biopsy. And these patients were generally the patients with humoral hypercalcemia of malignancy had this biopsy within a month or two of their diagnoses with HHM. And the shaded bar represents patients with humoral hypercalcemia of malignancy. And you can see what really stands out is the uncoupling of osteoclasts and osteoblasts. You can appreciate the marked increase in osteoclast surface in patients with humoral hypercalcemia of malignancy or PTHRP excess, and the decrease in the osteoblast surface. In contrast, we know that in primary hyperparathyroidism, these osteoclasts and osteoblasts remain largely coupled. Now, let's look at the skeletal effects of excess parathyroid hormone related peptide in children. We know that this is a rare occurrence, and so our observation is limited to published case reports with complete information. And excess PTHRP has been reported in conjunction with congenital anomalies of kidney and urinary tract. And I could only find 4 cases where both PTH and PTHRP levels were reported in these patients. And there was no apparent skeletal phenotype that was reported in these patients. More recently, there was a case that reported of a 10-month-old infant, and that patient, again, no apparent skeletal findings on CTs, pan-CT that was performed. So it seems that the skeletal effect of excess, at least postnatal PTHRP exposure, seems to be doesn't seem to be as dramatic. However, we still do not know what the effects of PTHRP exposure in excess PTHRP exposure in utero could look like, and it also begets these observations also beget the question if the elevated levels of PTHRP were actually high enough to or elevated enough to cause pathology of skeletal manifestations. So to summarize, we have seen that increased parathyroid hormones signaling can involve bones that undergo endochondral or intramembranous ossification. We have seen that radiographically in the long bones, we see lytic lesions with cortical thinning predominantly, and in the craniofacial bones, it appears to have a proliferating expansile lesions with diffuse calvareal thickening. And on histology, the common theme that emerges is increased osteoclastic activity with irregular and disorganized trabeculae, and areas of new immature bone formation with fibrosis of the bone marrow. I should mention, I forgot to mention earlier that fibrosis of the bone marrow is also seen in patients with severe hyperparathyroidism, which is not really commonly seen today. So let's move on to discuss the mechanism of action of PTH on the skeleton. Again, we know. So what do we know? What is our current state of knowledge? So we know that the effect of PTH on the skeleton depends on its mode of administration, whether it is administered intermittently versus continuously, on its timing of administration, whether it's administered chronically versus short-term use, and the dose, whether it's a low dose versus high dose. We also know that both teriparatide, which is PTH1 to 34, and abaloparatide, which is PTHRP analog, are used in the treatment of osteoporosis. And the maximum increase in bone mineral density in both from use of either of these peptides results is seen in the spine. So how does PTH really orchestrate this profound effect on the skeleton? So to understand that, let's review the effects of parathyroid hormone on target cells of the bone marrow and the skeleton. So you see here a bone marrow stromal stem cell, which has the ability to differentiate into an osteoprogenitor cell or into an adipocyte lineage cell. And what PTH does is that it inhibits the differentiation of these cells into adipocyte lineage and shifts them towards the osteoprogenitor lineage. At the level of these osteoprogenitor cells, PTH decreases the apoptosis of these cells. It also increases the expression of RUNX2, which is a master transcription regulator for osteoblasts and critical for osteoblastic activity. And then it also stimulates the differentiation of these osteoprogenitors into osteoblasts. And then PTH then further acts on these osteoblasts to decrease their apoptosis. It also increases Wnt signaling, which has bone, which is important for osteoblastic activity, and also upregulates the expression of some of these genes like fibroblast growth factor IGF-1, which are important for the maximum anabolic activity of PTH. PTH also acts on these lining cells in the bone to reactivate them towards osteoblasts. And then PTH also acts on these osteocytes to decrease the secretion of sclerostin and increases the rankle secretion from these cells. So really profound effect on different target cells in the bone and the skeleton. We should to recall that there are no PTH1 receptors expressed on the osteoclast. So the effect on osteoclast is predominantly through the increased secretion of rankle, which promote the differentiation of immature osteoclasts into mature osteoclasts. PTH also acts on T lymphocytes and increases the secretion of Wnt10b and CD40 ligand, which are important for osteoblastic activity. And it also increases the expression of interleukin 17 from these cells, which promotes the secretion of rankle from osteocytes. So again, you can appreciate here the profound effect that PTH has on these different cells in the bone marrow and skeleton. And so PTH really there are multiple complementary things that are happening for PTH to orchestrate both the bone forming and bone resorbing effect on the skeleton. So you can see PTH. We know that the bone forming effect of the PTH is predominantly through its effect on inhibiting the secretion of sclerostin. We also know that the bone resorbing effect of PTH is predominantly through its role in increasing the secretion of rank ligand. So, so both sclerostin and rank ligand are secreted predominantly by osteocytes. And so osteocytes appear to be a major cell which orchestrate the profound effects that PTH has on the skeleton. And so uh, recent studies have elucidated the intracellular parathyroid hormone signaling in the osteocytes, and through an elegant series of experiments done by Dr. Mark Wine at the MGH, salt-inducible kinases type 2 has been identified as an important link that really orchestrates the effect of PTH in both bone formation and bone resorption. It remains to be seen if this pathway is also seen in other target cells of the bone marrow and the skeleton. And the other thing to note here is salt-inducible kinase is actually being targeted for drug development, and inhibitors that target this kinase are currently in development for treatment of osteoporosis. So with that, I it's a little bit of a detour, but I did want to mention briefly about hungry bone syndrome, particularly with reference to primary hyperparathyroidism because, we diagnose these patients and we refer them for surgery. And these patients, when post-surgery, these patients can develop something that called hungry bone syndrome, where these patients can have profound and prolonged hypocalcemia after surgery. And the nadir of serum calcium is usually seen in postoperative days 2 to 4. This may also be associated with hypophosphatemia and hypomagnesemia. And hungry bone syndrome is most commonly seen, or the risk factors at least are, older age, severe hypercalcemia, preoperative skeletal disease, or PTH-related skeletal disease, vitamin D deficiency, and prolonged time to diagnoses. And so always have to remember that while managing these patients. Let's change gears a little bit now and move to discussing genetics of primary hyperparathyroidism. So we generally think of primary hyperparathyroidism in two buckets. 90% of these patients have what we call sporadic primary hyperparathyroidism. But about 10 to 15% of these patients have what we call heritable forms of primary hyperparathyroidism. I should point out that primary hyperparathyroidism is the most common parathyroid disorder, and its overall prevalence is about 0.85% in the general population. And uh, and to get back here, so about 10 to 15% of these patients who have primary hyperparathyroidism will have heritable forms, and these can be categorized under syndromic forms or non-syndromic forms. And we will review each of these in the subsequent slides. On the left side, these sporadic forms of primary hyperparathyroidism can actually be caused by any of these genes mentioned under the heritable forms when the variants are noted in the somatic form. I have provided here the histological diagnoses of primary hyperparathyroidism, where this can be due to a parathyroid adenoma. It could also be due to, rarely, it can be due to parathyroid carcinoma. Again, very rare, less than 1%. And even rarer is a condition called parathyroidomatosis, where there's microfoci of parathyroid tissue that is seeded throughout the neck. Again, both parathyroid carcinoma and parathyroidomatosis are extremely rare histological diagnoses. So who should really be offered genetic testing in primary hyperparathyroidism? So, the foremost thing is family history. Family history is the strongest predictor of positive genetic test. The second bucket to think of would be multi-gland disease. Multi-gland disease. Multi-gland disease. And multi-gland disease could be synchronous or these could be asynchronous. Recurrent disease or persistent disease, patients that develop primary hyperparathyroidism at a young age. Uh, Studies have shown that in patients younger than 45, the yield of a genetic test could be as high as 10%. And again, patients whom you suspect either you're suspecting them, or they report a family history of parathyroid cancer. Or when patients in whom you're concerned about FHH, familial hypocalciuric hypercalcemia, and all patients where you're concerned about MEN1, those that have the extraparathyroidal manifestations of gastrinomas or multifocal pancreatic neuroendocrine tumors, or even those who meet the criteria of clinical criteria of MEN1. So, and what are the benefits? Similar to other conditions, it allows you to offer cascade screening to family members. You can diagnose these patients with some of these syndromic forms, which impacts their management. You can institute surveillance for associated manifestations in these syndromic forms. And again, in patients, you can test family members, and in the case of a negative test, you relieve them of the burden of chronic surveillance with these multiple imaging studies and blood work throughout their lifetime, and the anxiety, and also provide access to pre-implantation and prenatal genetic testing for in patients who wish to do so, in the individuals with a positive genetic test who wish to do so. So let's move on to review the heritable syndromic forms real quick. So the syndromic, this table here shows the syndromic forms that are listed that are known to date. And the last three bolded ones actually are the ones that have only been come to attention in the last few years, more recent years. And I want to point out here that multiple endocrine neoplasia type 1 is the most common syndromic form of primary hyperparathyroidism. You can these are the list of genes, and what I would like to point out here is that most of the genes that cause these syndromic forms appear to do so by loss of function. The only oncogene mentioned here is the red gene, where these variants are gain of function mutations. And very recently, as just a couple of months ago actually, what was reported is a syndrome called X-linked intellectual disability syndrome, which we will talk about in the next few slides. And it is unclear if the variants in this gene are activating or loss of function mutations. So what I wanted to show here is that the first syndrome, MEN1, as I mentioned, is very common. This is a busy slide here, but what I wanted to show is that almost all the patients with MEN1 develop primary hyperparathyroidism. The syndrome is caused by a loss of function of the MEN1 gene, which codes for menin, which functions as a tumor suppressor. And these patients, in addition to, as you can see, have several other tumors all over the endocrine, predominantly endocrine tissues, but also non-endocrine tissues. However, these patients typically present with primary hyperparathyroidism. That is their earliest manifestations, and almost all patients with MEN1 will develop primary hyperparathyroidism. So, you know, we should constantly be thinking of the syndrome, and because you have the ability to diagnose these patients with the syndrome and change their management. So the one thing to note is, again, these patients will present early, and these patients do have a very recurrent course of primary hyperparathyroidism. With almost 60% of these patients may develop a recurrence within 10 years, even after subtotal parathyroidectomy, when you remove 3.5 glands. So we'll go out of sequence a little bit, but the next condition that I wanted to talk about is MEN4, or multiple endocrine neoplasia type 4. Again, this is caused by a loss of function mutation in cell division kinase N1B gene. And this is it mimics the manifestations mimic MEN1. It has a prevalence of up to 4% in patients that present with MEN1-like manifestations. So again, young patients presenting with hypercalcemia. And what we to keep in mind is that these patients generally have a milder disease course. So they occur later. They have a lower likelihood of recurrence. And the last one here is MEN2, previously known as MEN2A. And only about 30% of these patients develop primary hyperparathyroidism. It's really, doesn't primary hyperparathyroidism doesn't appear to be a prominent manifestation in this syndrome. And these are caused by activating mutations in the RET oncogene. MEN2B, what was previously called MEN2B is now called MEN3, and hyperparathyroidism is not seen. This is also caused by RET gain of function variants in the RET gene. And again, parathyroid tumors are not associated in that syndrome. So we'll talk next about hyperparathyroidism jaw tumor syndrome. We had recently reported our cohort of patients. And again, this syndrome is caused by germline CDC73 variants. CDC73 is a cell division cycle 73 gene. It is a part of, it codes for parafibromin, and it is a part of RNA polymerase II. So we had reported our experience of 68 patients, and what we noted is that almost 80% of these patients develop primary hyperparathyroidism, and about 30% of these patients develop parathyroid cancer. So it's really the most frequent gene to be mutated in patients with parathyroid cancer. And these patients also develop jaw tumor, which are histologically cemento-ossifying fibromas. The disease gets its name because the kindred that it was first described of the primary hyperparathyroidism co-segregated with jaw tumors. However, we know today that jaw tumors are relatively uncommon in the syndrome and only is seen in up to about 10% of these patients. And in addition, these patients also get some of these other tumors. The most intriguing thing about this gene is this incomplete penetrance. So we'll present to you this case here where we had this proband shown here with the black arrow. The proband presented to us at the age of 24 years with primary hyperparathyroidism. He presented actually at the age of 16 years and with profound hypercalcemia and was diagnosed with parathyroid cancer post-operatively. He really denied any history of primary hyperparathyroidism or related manifestations in his parents. But on pedigree charting, he reported a history of primary hyperparathyroidism in his paternal grandfather and his paternal uncle, indicating that his father was an obligate carrier of the variant. So it is because of incomplete penetrance of this gene that prophylactic parathyroidectomy is not recommended in this condition. In, Now, a few years ago, my colleague Dr. Bill Simons had reported on the genotype-phenotype correlation in this syndrome. So basically, he divided patients who are seen in our cohort into two groups: those that had truncating mutations, so frame shift mutations, large deletions, were categorized as high impact mutations, and those that had missense mutations were categorized under low impact mutations. And what was seen was that the patients with these high impact mutations had a 6.5-fold increased risk of developing parathyroid cancer. So again, something to keep in mind as we counsel these patients. In addition, we also know that CDC73 variants are rare in sporadic adenoma. So it seems to account for a much fewer proportion of benign tumors, but a much higher proportion of sporadic parathyroid cancers, up to 75%. So that's again, this is work that was published in the New England Journal back in early 2000s. And so that was CDC 73. And then I'll move on to discuss some of the more recent work that we had reported last year. And we reported variants in this folliculin gene as only the second gene to account for a significant proportion of patients with parathyroid cancer. And, we already know that inactivating or loss of function mutations in this gene cause what we call Birt-Hogg-Dubé syndrome, where patients develop fibrofolliculomas, they develop lung bleps, and they also develop heritable kidney cancer. What our findings showed was that in our cohort of patients with parathyroid cancer or genetically unexplained parathyroid cancer, loss of function mutations in folliculin explained 20% of our patients. And these were seen in both germline or somatic forms. And in patients with germline variants, we actually showed biallelic inactivation. And you can see this is the tumor DNA Sanger sequencing here on the tumor DNA of this patient. And you can see that there was loss of heterozygosity. This is Sheeny. I know it's a little bit fuzzy here, but you may be able to appreciate that there's loss of heterozygosity on the tumor DNA, supporting that this is related to the folliculin gene. So again, so folliculin, we had also sequenced folliculin. We had also performed PCR sequencing for folliculin in about 75 sporadic parathyroid adenomas to see if we could, if this was also seen in benign parathyroid adenomas, and we didn't see any. So really, it seems like folliculin loss appears to be a frequent cause or a relatively frequent cause of parathyroid cancer. We also know from studies done in renal tumors that folliculin loss results in mTOR activation. And so whether this pathway, whether this is also the mechanism by which folliculin loss results in primary hyperparathyroidism remains to be seen. There is no parathyroid cell line, there are no in vitro models, so which limits our ability to study the mechanism in parathyroid tissue. But we are working on animal models to study this further. Now, follow-up studies have been reported since then. This is work from Dr. Andy Arnold's lab that sequenced DNA from 26 parathyroid cancer or atypical parathyroid tumor samples and did not identify any variants in folliculin. And then more recently, there's a case report from a patient in the Middle East who presented with hypercalcemia, was diagnosed with parathyroid cancer, and and then on genetic testing was noted to have BHD syndrome. So again, more to come as we navigate through this. And again, more recently, what has been as early as this year, actually, just a few months ago, a novel syndrome, the X-linked intellectual disability syndrome, has been reported to be caused by a zinc finger protein family gene ZFX. This is a gene that's located on the X chromosome, and it's a really intriguing gene. This protein is actually essential for survival of hematopoietic and embryonic stem cells, and overexpression has been associated with poor prognosis in various cancers. What they showed in their work, Shefferson et al. In 2024, earlier this year, that a zebrafish model of ZFX loss, they had truncating mutations there, displayed altered behavior, which was consistent with the syndrome. However, in their cohort, primary hyperparathyroidism was only seen in missense variants, of this gene, and all the missense variants that showed primary hyperparathyroidism are located in the zinc finger domain 12 and 13. So it is unclear if in parathyroid tissue these missense variants, this gene with a missense variant really functions as the variants really result in a loss of function or a gain of function of this gene. So, and the other intriguing thing to note about these patients is that both the alleles of ZFX were expressed in females with primary hyperparathyroidism. We know that one of the X chromosome undergoes inactivation, but in these females with these ZFX associated tumors, the gene seems to escape X inactivation. We don't know how what's the relevance of this skewed inactivation of X in towards the pathogenesis of parathyroid tumors, but more to come. And so this is really the clinical phenotype of these patients with ZFX-related primary hyperparathyroidism. What I want to point to your attention is really that these patients can present really early, even at age 12. And then we'll move on to discuss the non-syndromic forms. Really, the non-syndromic forms we've talked about CASR in the last few talks. So the non-syndromic forms, again, familial hypocalciuric hypercalcemia is the most common. And we also have, in the more recent years, what the two new genes that have come up is GCM2 mediated primary hyperparathyroidism, and again, transient neonatal hyperparathyroidism, that is associated with TRPV6, or this codes for a calcium channel. So again, most of these are inactivating mutations except for GCM2, which is activating a mutation and functions as which is an activating mutation. So let's quickly review the calcium sensing receptor pathway. I'm not going to go through this pathway since we've heard that in the last few talks, but I just wanted to point out that calcium sensing receptor again exists as a dimer. Inactivating mutations of the calcium sensing receptor results in familial hypocalciuric hypercalcemia type 1. Inactivating mutations of GNA11 result in familial hypocalciuric hypercalcemia type 2, and inactivating mutations in this adaptor protein 2 results in FHH type 3. Again, all these three genes are part of the calcium sensing receptor pathway. And in these patients with FHH, really, the reason to really try to diagnose these patients is because they have the target organ damage is rarely seen in these patients. So they rarely develop kidney stones or osteoporosis. And hence, the utility of parathyroidectomy is there's no benefit to them. So, and then rarely, again, calcium sensing receptors can be mutated in a homozygous or compound heterozygous variants of calcium sensing receptor, result in what we call neonatal severe hyperparathyroidism. These infants present with severe hypercalcemia. It's potentially life-threatening. They develop a bell-shaped narrow thorax, and really, in terms of the skeleton, they present with subperiosteal erosions. You may be able to appreciate on these X-rays in diffuse bone demineralization. And these patients are managed with urgent parathyroidectomy. Cinacalcet may be used as a temporizing measure. And as I'd mentioned, our group had reported on GCM2, which codes for glial cell missing 2 gene, back in 2016 as a novel cause of primary hyperparathyroidism. These are, again, germline activating variants. However, follow-up studies have now illustrated that GCM2 variants in GCM2, these variants appear to be more of a low penetrance predisposition allele rather than a causative gene of primary hyperparathyroidism. And so GCM2 encodes for this transcription factor, which is critical to the development of which is critical for the development of parathyroid glands. And we also know that loss of function mutations in this gene result in hypoparathyroidism. So all the missense variants that have been reported to be associated with primary hyperparathyroidism, they are concentrated in the C-terminal inhibitory domain of this gene. But these variants also appear to be very common in Ashkenazi Jewish population, particularly the Y394S variant. And so population studies have shown that 96% of individuals with the variant do not develop hyperparathyroidism. So the penetrance is estimated at about 0.5%. And this is also supported by knock-in mouse models that have shown that these models develop normal biochemistry and normal-sized parathyroid glands. However, this does appear to be a predisposition allele because when crossed with a cyclin D1-driven mouse model, these mice develop primary hyperparathyroidism. And then the last gene condition that I want to bring to your attention is this transient neonatal hyperparathyroidism. Biallelic inactivating variants in transient receptor vanilloid subfamily member 6 or TRPV6 gene results in this condition. Essentially, this codes for a calcium selective ion channel, which is expressed in epithelial tissues such as placenta, or pancreas, salivary glands, etc. But really, what's happening is loss of function of this gene results in impaired transplacental calcium transport, which results in poor bone mineralization and leads to bell-shaped chest, in subperiosteal resorption, and similar to what we saw in the neonatal severe hyperparathyroidism state. So this is a transient condition, and these patients typically, these skeletal manifestations typically normalize with calcium supplementation within 2 years of birth. Again, this is only published in 2018, first report in 2018, so more work needs to be done. But and then in heterozygous state, there does not appear to be any skeletal or mineral phenotype in in these patients. However, heterozygous state has been reported to be associated with early onset chronic pancreatitis. So this is the clinical biochemical phenotype of these patients here. And these infants, as you can see, appear to have normal calcium levels. However, look at their PTH levels. It's pretty dramatic, isn't it? And then look at their alkaline phosphatase levels in these infants. And then, in the end, there's always this idiopathic familial hyperparathyroidism where the genetic cause remains unknown. And I want to point out that in almost 80 to 90% of these families, the genetic cause remains unknown. And discovery of new causative gene will help us identify additional key genes that regulate PTH secretion or cell proliferation in the parathyroid gland or in general. So, so to conclude, as I wrap up, here are the conclusions. So despite much progress, our understanding of the actions of parathyroid hormone on target cells of the human skeleton is incomplete. It's a very complex complicated. It's a very complex, profound effect on the skeleton, and the effects appears to be compartment specific, which with predominantly proliferative expansile effect on bones that undergo intramembranous ossification, and predominantly lytic effect on the bones that undergo endochondral ossification. Primary hyperparathyroidism demonstrates significant genetic heterogeneity with variants in different genes resulting in similar phenotype, and most variants result in increased parathyroid cell proliferation, which leads to primary hyperparathyroidism. And again, I cannot emphasize enough that genetic testing should be performed in select patients with primary hyperparathyroidism. In general, the studies in primary hyperparathyroidism to support genetic testing are less robust, and that's why less robust in terms of how you can impact their overall overall mortality. However, as I've shown you, as I've indicated, diagnosing MEN1, diagnosing FHH does impact their management. So with that, I would like to thank my amazing research team, and our collaborators both from NIH and outside, and also the patients and their families and the patient foundations, NIDDK for the funding, and NIH Clinical Center, which allows us to bring these patients and study them for our research. Thank you so much for your attention.